And in the next 15 minutes, I will try to summarize how I manage transplant candidate, if the transplant myelofibrosis candidate for transplant. And the relevance of this topic is well represented for me by this graph, where as you can see, the number of transplant procedures doesn't work. The number of transplant procedures is steadily increasing over time, as well as median age of transplantation. And this is, for me, caused by basically three key points. Of course, the improvements in transplant platforms, but also better patient selection and better management pre-transplant. As all of you are very aware, the patient classified at low risk according to the standard disease-related risk prognostic index are not good candidates for transplantation. As you can see in the upper left, patient receiving transplant and worse outcome compared to non-transplant patients. On the contrary, a patient at intermediate 2 or high-risk disease have a better survival with a transplant approach. And even if you look at the intermediate 1 risk category, after the first year from transplantation, where the sharp drop in the survival curve, then we can observe a sort of plateau, suggesting that in selected cases of myelofibrosis patient, we can consider also transplantation in such category. And more importantly, the impact of transplantation on survival was consistent among patients receiving ruxolitinib or not. Now, we have seen which are the patients who can be evaluated for transplant, but now we have to select which patients are eligible for transplant. And in this context, we have to consider several aspects. Rather than the status, of course, and the presence of comorbid conditions, we have to consider the emotional sphere, the psychosocial status, the presence of geriatric syndrome, as we are talking about elderly patients usually. And we should think about the functionality, the presence of polypharmacy, and nutritional status. All these aspects contribute to a successful outcome of a transplantation. One of the, as we have seen before, one of the useful tools for selecting and for counseling patients for transplantation is represented by a myelofibrosis transplant scoring system. These scores include both transplant-related, non-transplant-related, patient-related characteristics, as well as disease-specific characteristics. And as you can see here, a patient with a score of 5 or more than 5 present a shorter survival after transplantation because of increased non-relapse mortality, and these patients should be evaluated for different approach probably. At our institution, we focus our attention on comprehensive geriatric assessment, and in particular on field score. Field score is a CGA developed by the Italian Foundation of Lymphoma, who combines age, a geriatric-specific comorbidity score, the CIRSG, the activity of daily living, and the instrumental activity of daily living, making it a quite comprehensive tool for the evaluation of elderly subjects eligible for intensive chemotherapy. As you can see, this tool was recently validated on a cohort of 228 elderly patients submitted to transplantation at our institution and in Paris from Professor Moti Center. As you can see here in the patient characteristic, 8% of those patients were affected by myelofibrosis. As you can see in the curve, this score was highly predictive of overall survival, due to specifically identifying patients at high risk of non-relapse mortality. And we have seen the patient, the right patient in the right moment, but now we have to drive him through the journey to the transplantation. And so we have to reduce iron overload, we have to improve his condition, and reducing splenomegaly to achieve a better result. What about the importance of anemia? This was the primary study who documented that an high transfusion burden significantly affected transplant outcome, with patients receiving more than 20 transfusions having a worse survival. And this is, of course, due by advanced disease, but also to iron overload. Iron overload may increase the risk of many different transplant-related complications. We know that iron overload in the bone marrow can cause a pro-inflammatory microenvironment that can contribute to a higher risk of poor graft function and graft failure that it's very frequent in myelofibrosis transplant patients. Also, the iron overload in the liver cells can induce liver abnormalities, leading to chemo-related toxicity and increased risk for sinusoidal obstructive syndrome. And iron overload was also associated to an higher incidence of infection, and particularly fungal infection. So our management of anemic patients is consistent with that recently reported by the NCCN guidelines. We, of course, have to rule out every possible coexisting cause of anemia and possibly to correct it. And then if a EPO value is lower than 500, we use ESA as a fourth option. In non-responders or in patients with higher EPO value, we use danazole or steroids, sometimes immunomodulating agent, or clinical trial whenever possible. And the efficacy of iron chelation was reported by the Rete Hematologica Lombarda, where we collected a cohort of around 40 patients with transfusion-dependent anemia receiving deferasirox. In this report, we documented that a lower ferritin at deferasirox start, a lower number of red blood cells infused, and the shorter time to treatment start were associated to an higher proportion of iron chelation response, and more importantly, iron chelation response was associated to a prolonged survival. Another aspect we have to take into account when dealing with myelofibrosis transplant candidates is the presence of splenomegaly. Splenomegaly is the hallmark of myelofibrosis, is present and very used in the large majority of our population. And increasing spleen size is very clearly associated with worse transplant outcome due to an excess of non-relapse mortality. And this is true also among those patients receiving JAK inhibitors. And the easiest way to manage splenomegaly in this context is represented by JAK inhibition, and the first-in-class JAK inhibitor, ruxolitinib, is very effective in reducing splenomegaly, and it can give a long-term response. However, we can also consider other JAK inhibitor. Now we have available fedratinib, possibly pacritinib, particularly in those patients with low platelet count. The role of ruxolitinib was confirmed also among patients receiving transplantation, with those patients responding to the drug in terms of spleen response, achieving a better event-free survival. And this reinforced the concept to titrate the dosage of the drug at the maximum tolerated dose, also at cost of hematological toxicity, in order to achieve a better result. Now, what to do in case of ruxolitinib or JAK inhibitor failure? We can choose a second generation TKI, such as fedratinib. Fedratinib has been reported to increase the number of responders patients around 30% in Rux-treated category. We can use involved field radiotherapy before transplantation, but this is not very widely available procedure, and also it's burdened by not negligible risk of infection and cytopenias. And the third option, where more information is available, is splenectomy. Splenectomy was recently proved to induce a better overall survival among transplant myelofibrosis compared to patients submitted for transplant with spleen palpable more than 15 centimeters below left costal margin, and this was due to a better non-relapse mortality without a significant increase of relapse risk. All these considerations led to the drafting of EBNT recommendation that will be soon available on Lancet Hematology that were produced by a multidisciplinary expert panel who state to treat patients with a splenomegaly more than 5 centimeters below left costal margin or with constitutional symptoms with JAK inhibitors in order to achieve a good spleen response, at least below 5 centimeters below left costal margin. And in those patients who are not achieving such a good response, and particularly in those with a spleen palpable more than 15 centimeters below left costal margin, we should consider before transplantation alternative approach such as JAK inhibitors, splenectomy, splenic irradiation, or clinical trial. So this is my last slide. To sum up, this is what we do in Brescia. After a careful patient selection for disease-specific and patient-specific characteristic, when dealing with donor selection and allogeneic stem cell transplantation planning, we treat anemia and/or thrombocytopenia with steroids, erythropoietin, androgens, or immunomodulating agent. In case of transfusion-dependent anemia and ferritin values higher than 1,000 or more than 10 red blood cells packs infused, we use iron chelation with deferasirox. And in those patients with splenomegaly, we use JAK inhibitors titrated at the maximum tolerated dose in order to achieve a good spleen response in order to safely proceed to transplantation. In those patients not achieving a good response, we consider as a first option a splenectomy, and then in 1-3 months we go through the transplantation or splenic irradiation. Let me thank all the colleagues of the clinical team and laboratory, our national and international collaborators, and you all for the attention. I will be very happy to receive any possible question. Thank you.